Hyperuricemia and gout. Larry N. Swanson. Introduction. Definitions. 1. Hyperuricemia refers to a serum uric acid level that is elevated more than 2 standard deviations above the population mean. In most laboratories, the upper limit of normal is 7 mg CEL uric acid method. However, the level varies with the laboratory method used. The upper limit of normal is about 1 mg DL lower for women than for men. 2. Gout is a disease that is characterized by recurrent painful acute attacks of uric crystal-induced arthritis. It may include tophi, deposits of monosodium urate, in and around the joints and cartilage and in the kidneys, as well as uric acid nephrolithiasis. B. General information 1. The prevalence of gout is believed to be between 3 and 5 million individuals in the United States. 2. Most gout victims are men, 7 to 9 times more often than women. Most women with the disease are postmenopausal. 3. The mean age at disease onset is 47 years. 4. The risk of developing gout increases as the serum uric acid level rises. Virtually all gout patients have a serum uric acid level 7 mg CL. 5. Research shows that among patients with a serum uric acid level above 9 mg CL, the cumulative incidence of gout reached 22% after 5 years. 6. Gout has a familial tendency. 10% to 60% of cases occur in family members of patients with the disease. 7. Obesity, hypertension, hyperlipidemia, atherosclerosis, diabetes, and alcohol abuse are often associated with hyperuricemia and gout. Certain nutritional approaches, that is, achieving ideal body weight or limitation of alcohol intake, can treat both the hyperuricemia and the associated conditions. C. Uric acid production and excretion. 1. Uric acid, an end product of purine metabolism, is produced from both dietary and endogenous sources. Its formation results from the conversion of adenine and guanine moieties of nucleoproteins and nucleotides. Figure 43-1. 2. Xanthine oxidase catalyzes the reaction that occurs as the final step in the degradation of purines to uric acid. 3. The body ultimately excretes uric acid via the kidneys, 300 to 600 mg a day, 2/3 of total uric acid, and via the gastrointestinal tract 100 and 300 mg a day, 1/3 of the total uric acid. 4. Uric acid has no known biological function. 5. The body has a total uric acid content of 1 to 1.2 grams. The daily turnover rate is 600 to 800 milligrams. 6. At a pH of 4 to 5, that is, in urine. Uric acid exists as a poorly soluble free acid. At physiological pH, it exists primarily as monosodium urate salt. 7. Uric acid filtration, reabsorption, and secretion sites are shown in Figure 43-2. Hyperuricemia and gout 875. D. Cause. Hyperuricemia and gout may be primary or secondary. 1. Primary hyperuricemia and gout apparently result from an innate defect in purine metabolism or uric acid excretion. The exact cause of the defect usually is unknown. Hyperuricemia may result from uric acid overproduction, impaired renal clearance of uric acid, or a combination of these. B. Some patients with primary hyperuricemia and gout have a known enzymatic defect, such as hypoxanthine, guanine phosphorybosyltransferase, DHPRT deficiency or phosphorobosylum pyrophosphate synthetase synthetase excess, figure 43-1. C. Principally for therapeutic purposes. Patients with primary hyperuricemia and gout can be classified as overproducers or underexcretors of uric acid. 1. Overproducers, about 10% of patients, synthesize abnormally large amounts of uric acid and excrete excessive amounts, 800 to 1,000 milligrams daily on an unrestricted diet, or 600 milligrams daily on a purine-restricted diet. These individuals generally have a markedly increased miscible urate pool, 2.5 grams, guanine hypoxanthine PRP, inosinic acid, adenylic acid, nucleic acids, ribose 5-phosphate, feedback inhibition, guanylate acid, HGPRT, PRPP, PRP synthetase, xanthine oxidase, allantoin, urate oxidase, rasburicase, pegloticase, uric acid, glutamine, inhibited by allopurinol and febuxostat. Normal endpoint of purine. Metabolism in humans. Figure 43-1. Uric acid formation. HGPRT, hypoxanthine guanine phosphorobosyltransferase. PRPP, phosphorobosyl -1 pyrophosphate. Adapted with permission from DiPiero J., Talbert R., Yi G. et al. Pharmacotherapy, a pathophysiologic approach. 8th ed. New York, McGraw-Hill, 2011. 2000. 876, Chapter 43. The 2. Underexcretors. About 90% of patients generally produce normal or nearly normal amounts of uric acid, but excrete 600 milligrams daily on a purine-restricted diet. They generally have only a slightly increased miscible urate pool. Some underexcretors are also overproducers. 2. Secondary hyperuricemia and gout develop during the course of another disease or as a result of drug therapy. E. Hematological causes of hyperuricemia and gout associated with increased nucleic acid turnover and breakdown to uric acid. Lymphoproliferative disorders. 2. Myeloproliferative disorders. 3. Certain hemolytic anemias and hemoglobinopathies. B. Chronic renal failure. In this condition, reduced renal clearance of uric acid can lead to hyperuricemia. C. Drug-induced disease. 1. Aspirin and other salicylates inhibit tubular secretion of uric acid when given in low doses, for example, 2 grams say of aspirin. At high doses, these agents frequently cause uricosuriia. Cytotoxic drugs increase uric acid concentrations by enhancing nucleic acid turnover and excretion. 3. Diuretics, except spironolactone, may cause hyperuricemia. Most likely, this occurs either via volume depletion, which, in turn, increases proximal tubular reabsorption, or via impaired tubular secretion of uric acid. 4. Ethambutol and nicotinic acid increase uric acid concentrations by competing with urate for tubular secretion sites, thereby decreasing uric acid excretion. 5. Cyclosporin decreases renal urate clearance, as do pyrazinamide and levodopa. 6. Ethanol alters uric acid metabolism both by increasing uric acid production through an increase in adenine nucleotide catabolism and by suppressing renal uric acid excretion as a result of lactate inhibition of renal tubular uric acid secretion. Figure 43-2. uric acid filtration, reabsorption, and secretion sites. At the glomerulus, uric acid is filtered and enters the proximal tubule. There, approximately 99% of uric acid is reabsorbed into the bloodstream. At the distal tubule, uric acid is secreted. Subsequently, about 75% of the amount secreted is reabsorbed. Therefore, almost all urinary uric acid is excreted at the distal tubule. Hyperuricemia and gout 877. D. Miscellaneous disorders. Diabetic ketoacidosis, psoriasis, and chronic lead poisoning are examples of conditions that may cause hyperuricemia. E. Pathophysiology 1. Gouty arthritis develops when monosodium uric crystals are deposited in the synovium of involved joints. 2. An inflammatory response to monosodium uric crystals leads to an attack of acute gouty arthritis. Painful joint swelling is characterized by redness, warmth, and tenderness. A systemic reaction may accompany joint symptoms. 3. If gout progresses untreated, tophi or tophaceous deposits of monosodium uric crystals may be noted, nodules on ears, fingers, elbow, etc., which usually are not painful and can eventually lead to joint deformity and disability. Kidney involvement may lead to renal impairment. However, these developments are uncommon in the general gout population and represent late complications of hyperuricemia. 4. Renal complications of hyperuricemia and gout may have serious consequences. Acute tubular obstruction. 1. This complication may develop secondary to uric acid precipitation in the collecting tubules and ureters, with subsequent blockage and renal failure. It is most common in patients with gout secondary to myeloproliferative or lymphoproliferative disorders, particularly after chemotherapy when allopurinol is omitted. 2. Another agent, urate oxidase, rasburicase, may be used in the prophylaxis and treatment of hyperuricemia in pediatric patients with leukemia, lymphoma, and solid tumor malignancies who are receiving anti-cancer therapy. This agent works by converting uric acid into allantoin, which is 5 times more soluble in urine than uric acid. B. Urolithiasis. This condition is characterized by formation of uric acid stones in the urinary tract. Low urine pH seems to be a contributing factor. The risk of urolithiasis rises as serum and urinary uric acid levels increase. This condition is seen more often in patients who produce significant amount of urinary uric acid, 1,100 milligrams c. C. Chronic urate nephropathy. In this complication, urate deposits arise in the renal interstitium. It is generally agreed, however, that chronic hyperuricemia rarely, if ever, leads to clinically significant nephropathy. The presence of additional disease, for example, diabetes mellitus, hypertension, may explain the finding of nephropathy in gout patients. F. Clinical presentation. Clinical evaluation and the need for intervention depend on the clinical presentation. 1. Asymptomatic hyperuricemia. 2. Acute gouty arthritis. 3. Intercritical gout. 4. Chronic tophaceous gout. 2. Asymptomatic hyperuricemia is characterized by an elevated serum uric acid level but has no signs or symptoms of urate deposition disease, arthritis, tophi, or urolithiasis. A. Clinical presentation. Hyperuricemia in and of itself is not believed to be a disease. There also has to be evidence of deposition of urate in the joints, soft tissues, or kidney to routinely warrant drug therapy intervention. Certainly, the risk of symptom development and complications increases as the serum uric acid level rises. However, as many as 2/3 of patients with elevated serum uric acid levels will continue to remain symptom-free. It is difficult to predict which patients who have asymptomatic hyperuricemia will eventually develop hyperuricemia-related issues. Although hyperuricemia often occurs concurrently in patients with cardiovascular disease, diabetes, and hypertension, it has not been proven to be a causal factor for any of these conditions. Serum urate levels of up to 13 mg cl in men and 10 mg cl in women have not been shown to cause deterioration in renal function. B. Therapy. Therefore, urate-lowering drug treatment for most patients is not required. General interventions such as encouraging maintenance of good urine output to prevent uric acid stone formation, avoidance of high purine meats and fish, and regular medical exams to get serum urate levels and to check for clinical evidence of gout-related signs. 878, Chapter 43, Third. The third, acute gouty arthritis. This clinical presentation of gout is characterized by painful arthritic attacks of sudden onset. Pathogenesis. Monosodium urate crystals form in articular tissues. This process sets off an inflammatory reaction. Trauma, exposure to cold, dietary overindulgence, or another triggering event may be involved in the development of the acute attack. B. Signs and symptoms. 1. The initial attack is abrupt, usually occurring at night or in the early morning as synovial fluid is reabsorbed. This severe arthritic pain progressively worsens and generally involves only one or a few joints. A. The affected joints typically become hot, swollen, and extremely tender. 17th century. British physician Thomas Sydenham described his personal experience with gout this way. Now it is a violent stretching and tearing of the ligaments. Now it is a gnawing pain, and now a pressure and tightening. So exquisite and lively is the feeling of the part affected that it cannot bear the weight of bedclothes nor the jar of a person walking in the room. B. The most common site of the initial attack is the first metatarsophalangeal joint. An attack there is known as podagra. Other sites that may be affected include the instep, ankle, heel, knee, wrist, elbow, and fingers. 2. The first few untreated attacks typically last 3 to 14 days. The joint pain and inflammation completely resolves, even when not treated, and is a hallmark of the condition. Later attacks may affect more joints and take several weeks to resolve. 3. During recovery, as edema subsides, local desquamation and pruritus may occur. 4. Systemic symptoms during an acute attack may include fever, chills, and malaise. C. Diagnostic criteria. 1. Definitive diagnosis of gouty arthritis can be made by demonstration of monosodium urate crystals in the synovial fluid of affected joints. These needle-shaped crystals are termed negatively birefringent when viewed through a polarized light microscope. 2. Serum analysis usually reveals an above-normal uric acid level. However, this finding is not specific for acute gout. Other common serum findings include leukocytosis and a moderately elevated erythrocyte sedimentation rate. 3. A dramatic therapeutic response to colchicine may be helpful in establishing the diagnosis, but this is not absolute because other causes of acute arthritis may respond as well. 4. When fluid cannot be aspirated from the affected joint, a diagnosis of gout is supported by A. A prior history of acute monoarticular arthritis, especially of the big toe, followed by a symptom-free period. B. The presence of hyperuricemia C. Rapid resolution of symptoms after colchicine. Therapy 5. Other conditions that may mimic gout include pseudogout, calcium pyrophosphate dihydrate crystal disease, or septic arthritis. D. Treatment goals. 1. To relieve pain and inflammation. 2. To terminate the acute attack. 3. To restore normal function to the affected joint. C. Therapy. 1. General therapeutic principles. The affected joint or joints should be immobilized. B. Anti-inflammatory drug therapy should begin immediately. For maximal therapeutic effectiveness, these drugs should be kept on hand so that the patient may begin therapy as soon as a subsequent attack begins. C. Urate-lowering drugs should not be given until the acute attack is controlled, as these drugs may prolong the attack by causing a change in uric acid equilibrium. Urate-lowering agents can begin within 1 to 2 weeks after the resolution of the attack. 2. Specific drugs. Any of the following agents may be used. A. Non-steroidal anti-inflammatory drugs. 1. Indications. Most physicians consider these drugs the agents of choice, especially the newer NSAIDs. These drugs may be preferred when treatment is delayed significantly after hyperuricemia and gout. 879. Symptom onset, or when the patient cannot tolerate the adverse GI effects of colchicine. Begin with high doses for 2 to 3 days, then taper the dose rapidly over the next several days. A. Indomethacin (indocin) is usually given in a dose of 50 mg 3 times daily initially, then the dose is tapered. Significant pain relief is achieved within a few hours. Tenderness and warmth usually decreases over the next day and a half, with swelling disappearing within a few days. B. Specific NSAIDs, such as naproxen, naproxen, 750 mg followed by 250 mg every 8 HRS until the attack subsides, or Sulindac. Clanuril 200 mg twice a day. 2. Start reducing the dose with satisfactory response. 7 days of therapy are usually adequate, are specifically approved for this indication, but many other NSAIDs have been used successfully. There is no evidence that any particular NSAID is more effective than others in the treatment of an acute gouty attack. Some have also used selective cyclooxygenase 2, COX-2 inhibitors for these attacks. 2. Precautions and monitoring effects. Adverse effects of indomethacin are usually dose-related. These effects occur in 10% to 60% of patients and may require that the drug be stopped. They primarily include GI complaints of nausea and abdominal discomfort and central nervous system, CNS effects of headaches and dizziness. Because of these CNS effects, it should be avoided in the elderly. Indomethacin should be taken with food or milk to minimize gastric mucosal irritation. Precautions. NSAIDs, in general, require cautious use in patients with a history of hypertension, congestive heart failure, CHF, peptic ulcer disease, or mild to moderate renal failure. B. Colchicine, the traditional drug for relieving pain and inflammation and ending the acute attack. Colchicine is most effective when started within 24 HRS after symptoms begin, the period of maximal leukocyte migration. Some would use this agent only if the patient is intolerant to NSAIDs or for those patients who have used colchicine successfully in the past. Colchicine has been available on the market for many years as non-FDA-approved medication. The standard dosage regimen had not been carefully studied for effectiveness and safety. In August 2009, Colchicine brand of colchicine was approved for the treatment of gout in a new, lower dosage regimen. 1. Mechanism of action. Colchicine apparently impairs leukocyte migration to inflamed areas and disrupts urate deposition and the subsequent inflammatory response. It has no effect on serum urate levels. 2. Dosage and administration. Oral regimen. The new dosing regimen approved for Colchicine is as follows. 1.2 milligrams at the first sign of an acute attack, then give 0.6 milligrams 1 HR later, maximum of 1.8 milligrams within 1 HR. In the AGREE trial, this dose, 1.8 milligrams total, had similar efficacy to high-dose 4.8 milligrams total, but with less gastrointestinal adverse events, 23% against 77%. Previous older dosing regimens were as follows. 0.6 milligrams to 1.2 milligrams initially, followed by 0.6 milligrams every 1 to 2 HRS until pain relief occurred or abdominal discomfort or diarrhea developed or a total dose of 6 milligrams had been administered. The effective dose of colchicine in patients with acute gout was considered to be very close to which caused adverse GI symptoms. B. Intravenous IV regimen. In February 2008, the FDA asked that IV preparations of this agent should no longer be manufactured or shipped in the United States because of significant toxicity and fatalities. Precautions and monitoring effects. GI distress, for example, nausea, vomiting, abdominal cramps, diarrhea, has occurred in 50% to 80% of patients receiving oral colchicine in a dose-dependent manner. With the new dosage regimen, these side effects should be lower. Oral colchicine should be avoided in patients with peptic ulcer disease and other GI disorders. B. In the process that led to the approval of the marketing of Colchicine, fatal colchicine toxicity was noted in patients on standard therapeutic doses of colchicine, taken with 880 Chapter 43 3rd. Certain other drugs such as clarithromycin. Important drug interactions can occur in patients taking colchicine with P-glycoprotein, TGP, amiodarone, cyclosporin, tacrolimus, quinidine, erythromycin, and cytochrome P450. CYP3A4 inhibitors, azole antifungals, macrolide antibiotics, protease inhibitors. C. Chronic colchicine therapy, C4, may result in neuromyopathy, patient notes numbness, paresthesias, and/or weakness, which is more likely in patients with decreased kidney function. It is best to limit colchicine therapy to 6 months duration after goal serum uric acid is achieved. C. Corticosteroids. Corticosteroid intra-articular injections are particularly effective in patients with acute single-joint gout. The actual act of aspiration of the joint fluid alone can sometimes greatly reduce the extent of the pain of gout. Specific doses of these agents, corticosteroids, is related to joint size. An intra-articular dose of triamcinolone 8 mg in smaller joints, 10 mg in the knee. Methylprednisolone acetate, 5 to 25 mg per joint, or betamethasone 3 to 6 mg can be used. 2. Systemic corticosteroid therapy is another option, especially when either NSAIDs or colchicine cannot be given or have not been effective. As an example, oral prednisolone 20 to 60 mg they initially, with the dose tapered during a period of 5 to 7 days, can be useful without producing a rebound effect. Instant message betamethasone, or 7 mg, or IV methylprednisolone 125 mg are examples of other potential agents. Instant message ACth 40 units. Reduces inflammation by stimulating corticosteroid production by the patient's adrenal gland, plus it activates melanocortin type 3 receptors, may also be used. This agent may not be preferred because of the short duration of action. IV. Intercritical gout is the symptom-free period after the first attack. This phase may be interrupted by the recurrence of acute attacks. Onset of subsequent attacks varies. In most untreated patients, the second attack occurs within 2 years of the first, but in some it may be delayed for 5 to 10 years. A small percentage of patients never experience a second attack. If hyperuricemia is insufficiently treated, subsequent attacks may become progressively longer and more severe and may involve more than one joint. B. Treatment goals. 1. To reduce the frequency and severity of recurrent attacks. 2. To minimize urate deposition in body tissues, thereby preventing progression to chronic tophaceous gout. C. Therapy. 1. Non-drug urate-reducing measures. The following reversible factors can raise the serum uric acid level and should be addressed. Avoid selected high purine content foods, for example, primarily meats, including organ-rich foods like liver, sweetbreads, etc., and seafood. Treat obesity, avoid alcohol consumption, or alter drug therapy that may increase the serum uric acid, that is, change from a thiazide diuretic to a drug like losartan. C4. 3. The purine content of the diet does not usually contribute more than 1 mg/ml to the serum uric concentration. Weight reduction sometimes reduces the serum uric acid level slightly. However, crash diets should be avoided. Drinking 2 or more beers increased the risk of gout by 2.5-fold in one study, versus a 1.6-fold increase for other alcohol spirits. Wine intake was not associated with an increased risk of gout. High purine content vegetables don't appear to increase the risk of gouty attacks. Increasing low-fat dairy products in the diet, however, may lower serum urate. 2. Prophylaxis against a future gout flare after resolution of an acute gouty attack may consist of low-dose colchicine, 0.6 mg once or twice daily in the patient with normal renal function. A. Adverse effects from colchicine at these doses are usually uncommon. In patients, particularly the elderly, who develop loose or diarrheal stools, 0.6 mg every other day might work. B. Low-dose NSAIDs may also be used alternatively, naproxen 250 mg twice daily or indomethacin 25 mg twice daily. C. Generally, begin prophylactic drug treatment 2 to 3 weeks before urate-lowering drug therapy is begun and administer until the desired serum uric acid level is achieved. Prolonged use of hyperuricemia and gout. 881. These agents may prevent recurrent episodes of gouty arthritis, but they do not prevent the development of silent bony erosions and tophi deposits. D. If the patient develops signs and symptoms of an impending gouty arthritis attack, he can increase the dose to 1.2 mg followed by an additional dose of 0.6 mg 1 HR later. 3. Urate-reducing drug therapy. The goal for gouty attack prevention is to reduce the serum uric concentrations to value 6 mg. A reduction to 5 mg CUDL may be required for the resorption of tophi. The decision to begin drug therapy should be carefully considered, as urate-lowering drug treatment should be lifelong. Urate-reducing drugs include the xanthine oxidase inhibitors, allopurinol, xylopram, and febuxostat, Uloric, which reduce uric acid production, and the uricosuric agent probenecid, Benamid, which increases renal uric acid excretion. Uric acid lowering therapy should not be initiated during an acute gout attack, as this action may prolong the attack by changing the equilibrium of body urate. During the first 6 to 12 months of therapy, these drugs may increase the frequency, severity, and duration of acute attacks. Therefore, some clinicians administer prophylactic colchicine concomitantly during the early months of uricosuric therapy. C4, C2. Indications for therapy with a drug that lowers serum uric concentration should be considered when all of the following criteria are met. 1. The cause of the hyperuricemia cannot be corrected or, if corrected, does not lower the serum uric concentration to 7 milligrams. 2. The patient has had 2 or 3 definite attacks of gout or has tophi. The patient is convinced of the need to take medication regularly and permanently. B. Specific agents. 1. Allopurinol, xylopram. A mechanism of action. Allopurinol and its long-acting metabolite, oxypurinol, block the final steps in uric acid synthesis by inhibiting xanthine oxidase, an enzyme that converts xanthine to uric acid. Figure 43-1. Thus, the drug reduces the serum uric acid level, although increasing the renal excretion of the more soluble oxypurin precursors. This decreases the risk of uric acid stones and nephropathy. B. Indications. Allopurinol is considered by many to be the drug of choice for lowering uric acid levels because of its effectiveness in both under-excretors and overproducers. But it is specifically the preferred urate-reducing agent for patients in the following categories. I. Patients who are clearly overproducers, overexcretors of uric acid. Patients with recurrent tophaceous deposits or uric acid stones. Other patients with renal impairment, but dose needs to be decreased. Dosage and administration. It is recommended by the experts that allopurinol be given initially in a daily dose of 100 milligrams, then increased by 100 milligrams day once every 1 to 4 weeks, if needed. Typically, the uric acid level starts to fall after 2 days with maximal effect for a given dose in about 1 to 2 weeks. 300 milligrams once daily is the most commonly prescribed dose, but this may be an inadequate dose. A dose of up to 800 milligrams a day, in 2 to 3 divided doses, may be needed to achieve the desired 6 mg CEL serum uric acid level. The drug should be given daily without interruption. The dose should be decreased in patients with impaired renal function. 200 mg seed maximum for the patient with a creatinine clearance. 1 milliliters min to 100 mg day for a patient with a CRCL of less than 10 milliliters min, and the dosage interval lengthened if less than 3 milliliters min. D. Precautions in monitoring effects. Allopurinol is generally well tolerated. I. Side effects occurring in 3% to 5% of patients include rash, diarrhea, drug fever, leukopenia, or thrombocytopenia. About 2% of patients will develop a rash. Some are mild and can be treated by stopping the agent. Others are more severe. Stevens-Johnson's or toxic epidermal necrolysis. Approximately 20% of patients given both allopurinol and ampicillin together develop a rash. The most serious side effect of allopurinol, which occurs in about 0.1% of patients, is the allopurinol hypersensitivity syndrome, AHS, with exfoliative dermatitis, often with vasculitis, fever, liver dysfunction, eosinophilia, and 882. Chapter 43-4. C. Acute interstitial nephritis. It is more likely to occur in patients with renal disease who receive regular doses along with diuretic therapy and may be fatal, 25% of patients. Allopurinol may induce more frequent acute gout attacks. This risk can be minimized by administration of low doses and concurrent colchicine therapy. Allopurinol can result in enhanced effects of azathioprine and 6-mercaptopurine when taken together. 2. Febuxostat. Uloric is a selective xanthine oxidase inhibitor and is the first new drug to be approved in 2009 for gout in over 40 years. Unlike allopurinol, it is a thiazolcarboxylic acid derivative and not a purine-like core structure. Thus, it does not share the same severe hypersensitivity reactions with allopurinol. The usual dose is 40 mg, comparable efficacy to 300 mg allopurinol. The dose can be increased to 80 mg after 2 weeks if the serum uric acid remains above 6 mg C. No dosage adjustments are needed in patients with mild or moderate renal hepatic impairment. D. It is much more expensive than allopurinol and generally should be considered an alternative therapy to allopurinol, allopurinol treatment failure, hypersensitivity, or other major side effects. E. This agent can increase liver function tests. Baseline liver function tests, LFTs, should be taken upon initiation of therapy and repeated at 2 and 4 months. A slightly higher incidence of thromboembolic events has been reported with febuxostat compared with allopurinol. Patients should be monitored for signs and symptoms of myocardial infarction or stroke. 3. Probenecid benamide is now the only available uricosuric drug on the U.S. market. This drug is preferred for underexcretors. A. Mechanism of action. Probenecid blocks uric acid reabsorption at the proximal convoluted tubule, thereby increasing the rate of uric acid excretion. Figure 43-2. B. Indications. Uricosurics generally are used to reduce hyperuricemia in patients who excrete 600 mg of uric acid per day. C. Dosage and administration. Type. Probenecid is given initially in 2 daily oral doses of 250 mg for 1 week, then increased to 500 mg twice daily every 1 to 2 weeks until the serum uric acid level drops below 6 mg. Most patients respond to a dose of 1.5 grams day or less, maximum of 3 grams day. D. Precautions and monitoring effects. Patients should maintain a high fluid intake, at least 2 L a day, and a high urine output during uricosuric therapy to decrease renal urate precipitation. This action will minimize the formation of uric acid crystals in the urine and deposition of uric acid in the renal tubules, pelvis, or ureter, which may cause a reduction in renal function. Alkalinization of the urine is usually not necessary, but can be achieved with 1 gram of sodium bicarbonate taken 3 to 4 times daily, plus a high fluid intake of at least 2 L a day. Uricosurics are contraindicated in patients with urinary tract stones. These drugs generally are ineffective in patients with creatinine clearances below 50 to 60 milliliters min. Aspirin, and other salicylates antagonize the action of uricosurics. Daily low-dose aspirin for antiplatelet function probably does not have this effect to any extent. Probenecid is well tolerated by most patients, but it occasionally causes adverse effects. For example, GI distress 8% and hypersensitivity reactions 5%. Pegloticase was also approved in 2009 and is a form of uricase urate oxidase, which catalyzes the oxidation of uric acid to allantoin, which is water-soluble and easily excreted. It is indicated for the relatively small number of gout patients, 50,000 Americans, who cannot be treated with other urate-lowering drugs, refractory patients. Hyperuricemia and gout 883. B. It needs to be given by IV infusion every 2 to 4 weeks. C. Patients need to be closely monitored for anaphylaxis and infusion reactions. Pretreatment with antihistamines and corticosteroids is needed. A large percentage of patients develop pegloticase antibodies, which results in decreased effectiveness. P. Prophylaxis with colchicine or nonsteroidal agents is also appropriate. It is more expensive than other urate-lowering drug therapies. Other drugs that increase uric acid excretion: losartan kozar, an angiotensin II receptor blocker, ARB, might be a useful antihypertensive agent in the patient who has both hyperuricemia and hypertension, because this agent can lower serum uric acid levels by inhibiting the uptake of uric acid by the urate-anion exchange transporter in the proximal tubule. This effect is minimal or not seen in other ARBs. Fenofibrate Chicor is a fibric acid agent used to treat elevated cholesterol and triglyceride levels. It has been shown to decrease serum uric levels by increasing renal uric acid clearance, and would be a useful agent in the patient with both hyperlipidemia and hyperuricemia. C. Vitamin C may lower the serum uric acid level. One study noted a 0.5 mg EL decrease when 500 mg was given daily. Fifth, chronic tophaceous gout. This rare clinical presentation may develop if hyperuricemia and gout remain untreated for many years. Pathogenesis. Persistent hyperuricemia leads to the development of tophi in the synovia, olecranon bursae, and various periarticular locations. Articular cartilage may be destroyed, resulting in joint deformities, bone erosions, deposition of tophi within tissues, and renal disease. B. Clinical evaluation 1. Patients may develop large subcutaneous tophi in the pinna of the external ear, the classic site, as well as in other locations. 2. Typically, the urate pool is many times the normal size. C. Therapy. Allopurinol and probenecid may be given in combination to treat severe cases. Directions for questions 1, 3. Each of the questions, statements, or incomplete statements in this section can be correctly answered or completed by one of the suggested answers or phrases. Choose the best answer. 1. All of the following statements concerning an acute gouty arthritis attack are correct except which one? A. The diagnosis of gout is ensured by a good therapeutic response to colchicine, because no other form of arthritis responds to this drug. B. To be ensured of the diagnosis, monosodium urate crystals must be identified in the synovial fluid of the affected joint. C. Attacks frequently occur in the middle of the night. D. An untreated attack may last up to 2 weeks. The first attack usually involves only one joint, most frequently the big toe, first metatarsophalangeal joint. 2. A 42-year-old obese man has been diagnosed with gout. He has had 3 acute attacks this year, and his uric acid level is presently 11.5 milligrams. Upper limit of normal is 7 milligrams CO. He has no other diseases. Rational treatment of this patient during the interval period between gouty attacks might include any of the following except A. Acetaminophen or aspirin 650 milligrams as needed for joint pain. B. Probenecid. C. Colchicine. E. Allopurinol. A decrease in caloric intake. Study questions. 884, Chapter 43. 3. A 45-year-old man is admitted to the hospital with the diagnosis of an acute attack of gout. His serum uric acid is 10.5 milligrams cl. Normal is 3 to 7 milligrams dl. Which of the following would be the most effective initial treatment plan? Before treating this patient, immobilize the affected joint and obtain a 24-HR urinary uric acid level to determine which drug, either allopurinol or probenecid, would be the best agent to initiate therapy. B. Begin oral colchicine 1.2 milligrams initially, followed by 0.6 milligrams every 2 HRS until relief is obtained, gastrointestinal distress occurs, or a maximum of 8 milligrams has been taken. Also, begin probenecid 250 milligrams twice a day concurrently. C. Administer oral indomethacin 50 milligrams 3 times a day for 2 days. Then gradually taper the dose over the next few days. D. Administer oral naproxen 750 milligrams, followed by 250 milligrams every 8 HRS for 3 weeks. E. Give colchicine 0.5 milligrams intramuscularly followed by 1 milligram intravenous piggyback every 12 HRS for 2 weeks. Directions for question 4. The question in this section can be correctly answered or completed by one or more of the suggested answers. Choose the answer I. If I only is correct, B. If the third only is correct, C. If I and second are correct, D. If second and the third are correct, A. If I, 2, and the third are correct. 4. Allopurinol is recommended instead of probenecid in the treatment of hyperuricemia in which of the following situations? When the patient has several large tophi on the elbows and knees, when the patient has an estimated creatinine clearance of 15 milliliters min, when the patient has leukemia and there is concern regarding renal precipitation of urate. Directions for question 5. The incomplete statement in this section can be correctly answered or completed by one of the suggested answers or phrases. Choose the best answer. 5. In a patient who has had documented gouty arthritis and hyperuricemia and who also has hypertension, a preferred antihypertensive agent would be hydrochlorothiazide, valsartan, C. clonidine, D. lisinopril, E. irbesartan. 6. Which of the following best describes a current important point about the use of allopurinol in the treatment of intercritical gout? E. It is best dosed in a 2 months on and 2 months off pattern. B. It needs to be dosed twice daily because of its short half-life. C. It is the only currently available FDA-approved xanthine oxidase inhibitor on the market. D. It should be used in reduced doses if the patient has significant renal impairment. It can only be used in patients who are overproducers of uric acid. Answers and explanations. 1. The answer is A. C. The third B. Other forms of acute arthritis may respond to colchicine, so that the diagnosis of gout cannot be established unequivocally by a good response to this agent. A definitive diagnosis requires the presence of urate crystals in the affected joint, although the presence of other symptoms or laboratory findings may suggest a probable diagnosis of gout. 2. The answer is A. CI. 2. Both aspirin in doses 2 grams they can inhibit uric acid secretion. Weight reduction, allopurinol or probenecid to lower the serum uric acid levels, and prophylactic colchicine are all appropriate interventions in the interval phase to reduce the incidence of acute gouty attacks. 3. The answer is C. C. The third. 1. 4 to yes C. Of the selections, the most effective initial plan in treating an acute attack of gout is to administer indomethacin orally, giving 50 milligrams 3 times a day for 2 to 3 days, then gradually tapering the dosage over the next few days. Although joint immobilization is an appropriate initial step, drugs for pain relief should be administered as soon as possible. Uric acid modification therapy, allopurinol or probenecid, should not be initiated until the acute attack is under control. Initiating therapy with probenecid at this point may prolong the resolution of an acute attack of gouty arthritis, which can usually be accomplished within 7 days of said therapy. Colchicine should never be given intramuscularly because it causes tissue irritation. The IV form of this drug has been removed from the market. Hyperuricemia and gout 885. 4. The answer is E, I, 2, the 3 is C4. In the treatment of hyperuricemia, allopurinol is indicated rather than probenecid when large tophi are present. When the creatinine clearance is 50 to 60 milliliters min, probenecid would be ineffective. But the allopurinol dosage would have to be decreased when the patient is an overproducer of uric acid, and when there is a need to prevent the formation of large amounts of uric acid, for example, when conditions such as leukemia are present. The answer is B, C4. 3. The olsartan angiotensin II receptor blocker has been shown to increase urinary uric acid secretion and can, therefore, lower serum uric acid levels. Hydrochlorothiazide actually decreases urinary uric acid excretion and must be used cautiously in gout patients, if at all. The other antihypertensive agents mentioned have minimal or no effects on the serum uric acid. 6. The answer is D, is 3. Allopurinol must be given daily without interruption. Its principal metabolite, oxypurinol, has a long half-life, so once-a-day dosing is appropriate. Febuxostat is another xanthine oxidase inhibitor on the market. It can be used for both overproducers and hypoexcretors of uric acid. D is correct because doses do need to be reduced if the patient has renal impairment. 886. 44. Peptic ulcer disease and related acid-associated disorders. Paul F. Sony, Anthony E. Zimmerman. I. Introduction. Definition. 1. Peptic ulcer disease (PUD) refers to a group of disorders characterized by circumscribed lesions of the mucosa of the upper gastrointestinal GI tract, particularly the stomach and duodenum. The lesions occur in regions exposed to gastric juices. 2. Gastroesophageal reflux disease GERD refers to the retrograde movement of gastric contents from the stomach into the esophagus. Reflux may occur without consequences, and thus be considered a normal physiological process, or it may lead to profound symptomatic or histological conditions, for example, GERD. When reflux leads to inflammation with or without erosions or ulcerations of the esophagus, it is called reflux erosive esophagitis. Most patients, 50% to 70%, report typical symptoms but lack evidence of esophageal mucosal injury, non-erosive reflux disease, NERD. 3. Dyspepsia is defined as persistent or recurrent abdominal pain or abdominal discomfort centered in the upper abdomen. B. Manifestations. 1. Duodenal ulcers almost always develop in the duodenal bulb, the first few centimeters of the duodenum. A few, however, arise between the bulb and the ampulla. 2. Gastric ulcers form most commonly in the antrum or at the antral fundal junction. 3. Less common forms of peptic ulcer disease. A. Stress ulcers result from serious trauma or illness, major burns, coagulopathy not related to anticoagulant therapy, need for mechanical ventilation 48 HRS, or ongoing sepsis. The most common site of stress ulcer formation is the proximal portion of the stomach. B. Zollinger-Ellison syndrome is a severe form of peptic ulcer disease in which intractable ulcers are accompanied by extreme gastric hyperacidity and at least one gastronoma, a non-islet cell tumor of the pancreas or another site. C. Stomal ulcers, also called marginal ulcers, may arise at the anastomosis or immediately distal to it in the small intestine in patients who have undergone ulcer surgery and have experienced subsequent ulcer recurrence after a symptom-free period. D. Drug-associated ulcers occur in patients who chronically ingest substances that damage the gastric mucosa, such as non-steroidal anti-inflammatory drugs, NSAIDs. 4. Reflux esophagitis is most often recognized by the presence of recurrent symptoms, for example, heartburn or altered epithelial morphology visualized radiologically, endoscopically, or histologically. Heartburn is substernal burning or regurgitation that may radiate to the neck. Other symptoms include belching, water breath, chest pain, asthma, chronic cough, hoarseness, and laryngitis. B. Endoscopic evaluation detected Barrett esophagus. B in 6% of patients with frequent heartburn. Barrett's esophagus is a premalignant condition that may lead to adenocarcinoma of the esophagus or esophagogastric junction. Peptic ulcer disease and related acid-associated disorders 887. C. Epidemiology. 1. Incidence. Peptic ulcer disease is the most common disorder of the upper GI tract. The duodenal ulcers affect 4% to 10% of the United States population. Gastric ulcers occur in 0.03% to 0.05% of the population. B. Nearly 80% of peptic ulcers are duodenal. The others are gastric ulcers. C. Most duodenal ulcers appear in people between age 20 and 50. Onset of gastric ulcers usually occurs between age 45 and 55. D. The 1 to year point prevalence of active gastric or duodenal ulcer in the United States in men and women is about 1.8%. The lifetime prevalence of peptic ulcer ranges from 11% to 14% for men and 8% to 11% for women. E. Approximately 10% to 20% of gastric ulcer patients also have a concurrent duodenal ulcer. F. In the United States, 44% of the adult population experience heartburn at least once a month. 14% take some type of indigestion medication at least twice a week. Of patients with GERD symptoms who have undergone endoscopy, 50% to 65% have apparent esophagitis. G. The annual prevalence of dyspepsia in Western countries is approximately 25%. 2% to 5% of primary care consultations are for dyspepsia. 2. Hospitalization. A. Hospitalization rates in the United States for peptic ulcers have been declining. These rates dropped from 25.2 per 10,000 in 1965 to 16.5 per 10,000 in 1981. This reflects a decrease in hospitalization for uncomplicated cases owing to increased outpatient diagnosis and treatment. There has been little change in hospitalization rates since then. B. There has been little or no decrease in duodenal ulcer perforations, and only a slight decrease in hemorrhages. 3. Mortality. A. The mortality rate for gastric ulcers declined between 1962 and 1979 from 3.5 per 100,000 to 1.1 per 100,000. B. For duodenal ulcer, the mortality rate declined from 3.1 per 100,000 to 0.9 per 100,000. C. Although death from GERD is uncommon, morbidity is not, because of the prevalence of the well-recognized complications such as esophageal ulceration, 5%, stricture formation, 4% to 20%, and the development of Barrett columnar-lined esophagus, 8% to 20%. D. Description. 1. Ulcer size. The average duodenal ulcer typically has a diameter 1 centimeter. Most gastric ulcers are somewhat larger, 1 to 2.5 centimeters in diameter. 2. Most ulcers are sharply demarcated and have a round, oval, or elliptical shape. 3. The mucosa surrounding the ulcer typically is inflamed and edematous. 4. Ulcers penetrate the muscularis propria and, in some cases, extend into the serosa or even into the pancreas. 5. Fibrous tissue, granulation tissue, and necrotic debris form the ulcer base. During ulcer healing, a scar forms as epithelium from the edges covers the ulcer surface. 6. Nearly all duodenal ulcers are benign. Up to 10% of gastric ulcers are malignant. E. Cause. The two major observations regarding PUD are the causal relationship among NSAID intake, gastroduodenal mucosal injury, the pathogenesis of gastric ulcer, and, to a lesser extent, duodenal ulcer, and the association of Helicobacter pylori infection in the pathogenesis of duodenal ulcer, and, to a lesser extent, gastric ulcer. 1. H. pylori, formerly Campylobacter pylori, is a gram-negative microaerophilic, spiral bacterium with multiple flagella that lives and infects the gastric mucosa. This bacterium is able to survive in the acidic gastric environment by its ability to produce urease, which hydrolyzes urea into ammonia. Ammonia neutralizes gastric hydrochloric acid, HCl, creating a neutral cloud surrounding the organism. In the United States, the prevalence of H. pylori increases with age from approximately 10% at 20 years of age to approximately 50% at 60 years of age. Approximately